Good afternoon, everybody. Thank you for spending your lunch hour with us exploring California's LTSS system of care. My name is Maria Kalina. I'm the Executive Director of the California Collaborative for Long-Term Services and Supports, and I want to welcome you to our short but information-packed training session. A couple of brief housekeeping reminders just as people trickle into the webinar. First, to highlight that the session is being recorded. And we'll be circling back with each of you to share the recording, the slides, and some supplementary materials on LTSS. I do want to highlight that we've opened the chat, and I would encourage you to feel free to drop in questions and comments as we go along. I'm going to be really honest in saying that while we're hoping to have a few minutes at the end for Q&A with so much to cover, it's possible that we may be cutting it close. So we're going to do our best to respond to questions as they come in. And I would encourage collaborative members who are with us today to drop in resources, clarifying comments, or any information that you think might be helpful as we roll along. Don't be shy. I think this is intended to be a space for learning, so there's no such thing as a bad question. And lastly, I want to elevate that closed captioning is available for anyone who would like to enable the transcript. You can select the CC icon from your Zoom toolbar. Moving right along, just a little bit about the collaborative on this next slide. We are a statewide coalition comprised of advocates, providers, and consumer groups working towards a vision of an equitable, high quality, and sustainable system of LTSS care for California's older adults, people with disabilities, and caregivers. Our work as a coalition is focused on fostering understanding about the LTSS system of care. We do a lot to educate policymakers about the needs and challenges faced by older and disabled adults. We come together to develop policy recommendations for systemic improvements, and finally, harnessing our collective power to drive meaningful change. The next slide may be a little bit difficult to read given the smaller font, but this one lists all of our member organizations, and that includes our statewide partners as well as our network of regional coalitions that span 40 of California's 58 counties. We won't spend the time reading through all of these, but again, we will be sharing a copy of the slides, so you'll have this info handy. We wanted to start off today's session by really grounding ourselves in lived experience and hearing directly from older adults and people with disabilities about the challenges they face. So we're going to turn to a brief video. It's about 5 minutes long, where we'll hear from a diverse group of people across the United States. This video is part of a series called The People Say, and it features data from over 100 hours of interviews with people just talking about their lives. Again, the video does feature individuals from across the US, but the issues and challenges they raise ring so true here in California. So Nancy, if you don't mind, go ahead and hit play.
After I went through all this stuff and I hurt my back and I got cancer and this and that, I thought I would be able to get Medicaid. And so I filled it out and I was rejected. I said, well, maybe I didn't do something right. So I had a social worker when I was at the, what I call it the old folks home, the nursing home. And she said, well, yeah, you shouldn't have any problem with that. I'll help you fill it out and send it in for you, this and that. And she helped me fill it out, and I got all the information she wanted. I called the bank, and the bank sent me some my bank statements for the last 3 months, and I had some insurance for life insurance. My life insurance sent me a letter saying that I didn't get any money. I just had it, in case I get killed in an accident or something like that, And I sent all that stuff to them, and she sent it in, got rejected again.
Don't even talk about buying food. I ain't got, if it wasn't for her food stamps or my daughter, my oldest daughter getting food stamps or these free food banks and stuff, that refrigerator would be empty.
My ability to get from place to place is a problem because of my car. I can't drive my car now because of the brakes. Finances is as little money as I have coming in every month with Social Security, I am able to put away for emergencies. For if the kitties need to go to the vet. I always want to make sure. I was going to get my brakes fixed with some of that money, but sure enough, if I do, something's going to happen to the kitties. So I do have emergency money. So I would love to get a job again. I would love to go back to work. But it all comes down to not being able to afford to do that. I would need my car fixed.
No, yo no tengo casa. Este es un departamento que estoy rentando y que todo lo que me van de suplementar es para aquí, nomás para pagar renta y para pagar los biles. Si no fuera por las estampillas, entonces si tuviera hambre.
And this catch-22 you're describing, it's that people are kind of on the edge of eligibility for Medicaid. And then if they get a part-time job to help fill their time and have a hobby,
you're off of it.
Then you're off of it.
Then you're paying your Part B premium. You're paying 20% of your drugs, of your doctors or visits or tests. Well, that would take up all the money you're making. So you'd be right back where you were. And so why even try?
Yeah. What could?
But yet that would be fulfilling to be able to do that and to work again.
Worked my whole life. Had medical complication. Wound up in the hospital for 7 months. Got laid off. The federal plan, whatever it is, only lasted like 3 months, and I was in for 7 months. So they fired me. Came up to the hospital while I was high on drugs and fired me. I was high on drugs, pain medication.
She paid her taxes. She bought her house. And then because she owned her house and because she tried to save money to for her taxes and her insurance and her house, she had this money saved up. They wouldn't help her because they said she had money. She could use that to do her medical. And she said, but, you know, I've got other bills. But they don't want to hear that. I mean, I think that when you get older as a senior, you shouldn't have to pay any more property tax. I don't think that if you work as a senior, they should take out taxes. I mean, but Congress is not going to listen, or the government is not going to listen to us.
Have you applied for food stamps before?
Yes, I have several times. And they still, says I'm over the limit to qualify for them. But everything is so high till by me being retired, I still have the same bills that they don't have retirement price on this or that, or elderly price on this or that.
科嘅下咧，咁就可以改變醫療保險嘅一件事，咁你會改變乜嘢咧？
改變醫療保健呢件事啊？我會改變，即係我哋包括低收入同埋納稅人都一樣享有，大家同時享用有嗰個醫療福利，即係我哋啱又踏到嗰條線嘅人都唔冇，真係嗰班人真係好彷徨啊！好似人哋聽講啊，話加拿大呢，大家都有，咁就比較公平啲。
Thank you, Nancy. I just want to give a special thanks to the Public Policy Lab and the SCAN Foundation for going out into the field and capturing these important stories and voices. I think anytime that we can center policy and lived experience, we create meaningful change. So just switching gears a little bit, it is my pleasure to introduce Yasmin Palaid from Justice and Aging. Yasmin is joining us today to provide a very high-level overview of the aging and disability population in California. So we'll share a little bit of demographic data and then turn to a conversation about the LTSS system of care. So Yasmin, if you want to jump on.
Yeah. Hi, everybody. Like Maria said, my name is Yasmin Peled. I'm Director of Government Affairs for California here at Justice and Aging. And let's start walking through these slides. So, as you can see here, California's aging population is growing faster than any other age group. A statistic you'll hear over and over again anytime you hear any of us speak in other presentations or in committees is that by 2030, over 25%, 1 in 4 Californians is going to be over the age of 60. And this trend is expected to continue to rise. As you can see, all the other age demographics are trending downwards, but older adults are trending upwards. So let's move on. And then disability prevalence is also increasing, and especially with age. So the number of older disabled Californians is anticipated to increase 160% between 2015 and 2060. And from this pie chart, you can see here that the largest sector of individuals with disabilities is those between the ages of 65 and 74, which again is only projected to increase as the aging population increases. The state's older adult population is also becoming much more racially and ethnically diverse. So as you can see, white older adults, that is actually decreasing in the sort of overall majority in the state, while older adults of color are increasing. And so you can see here the trend between the major racial and ethnic groups. And by 2030, white non-Hispanic older adults will no longer represent the majority of older adults in California. So that's sort of along the side the fact that 1 in 4 older adults, 1 in 4 Californians will be older by 2030. It'll also be largely older adults of color. Next slide, please. And along with all of these trends is the fact that California's poverty rate for older adults and people with disabilities is much higher than those who are not. In this most recent Census Bureau in data that came out, older adults are often the only group that seems to keep having their poverty rates increase, actually, while everybody else's poverty rates seem to decrease. And this is a really alarming trend, and it requires significant investment from policymakers to reverse this really alarming trend. A lot of people are aging into poverty, which is contributing to this, but it's also the policies that we have in place for older adults that keep people trapped in poverty and don't allow them to have much economic security. Next slide, please. And another issue that older adults, especially here in California, are facing is that older adults are the largest population or the fastest growing group of individuals experiencing homelessness. And approximately half of California's older adults are age 50 and older. And many of those individuals are experiencing homelessness for the first time ever. So they're not individuals that have been chronically homeless for many years. A big contributor to the rise in older adult homelessness is rental cost. As you can see here on the left-hand side of the slide, 6 out of 10 older renter households are cost burdened and 4 out of 10 are severely rent burdened. So this means that people, older adults on fixed incomes really do not have the liquid cash and the economic security to be at the mercy of landlords and paying rent and paying significant rent increases because they just simply do not have the money, living on most likely very low fixed incomes. Next, please. So, with all of that background information, we're here to talk about long-term services and supports, which is called LTSS. And this refers to a really wide range of services. So there's a list here on the side here: personal care, transportation, care coordination, meal prep, grocery, housekeeping, errands, medication management, and much, much more. LTSS, as you'll see on the next slide, can mean a variety of things being provided in a variety of settings. And so this is where things start to get confusing, and there's lots of different terms for things that mean the same thing, but also terms that don't mean the same thing. There's lots of acronyms. And so I will do my best to try and explain some of this. But again, if there are questions, feel free to put it in the chat. And so home and community-based services is one of the main types of LTSS. So you can have home and community-based services which is to receive your care at home or in your community. And this is the main way that older adults and people with disabilities prefer to receive their care. People want to stay at home. They want to age in place. They want to be with their families, their communities. And that is the preference for many individuals. And so home-based care can be having a personal care aide, having a home health care aide, respite care, a caregiver who is either a family member or potentially someone who's coming in through the In-Home Supportive Services Program, IHSS, which is California's largest home and community-based services program, and we'll get into specific programs a little bit later in the presentation, but that's just an example of something that would be home-based. There's also the community aspect of home and community-based services. So community-based are things like assisted living, which in California are called residential care facilities for the elderly, RCFE, but they're oftentimes called assisted living. There's also adult day health care centers, which are places where adults can go during the day, older adults can go during the day to get care, to have social interaction. There's also services available to folks there. There's the regional center services, there are independent living centers, and then there's respite care. And then finally, there's the facility-based long-term services and supports. So this is for individuals needing that want and need a higher level of care in a facility setting, so like a nursing home. So people are probably familiar with skilled nursing facilities, sometimes called SNFs, SNF. And so this is what you would typically envision, somebody going to potentially after a hospitalization, or if someone is no longer to be cared for at home and needs sort of constant monitoring and medical attention on a sort of 24/7 basis. Nursing facilities can fill that need. There are also intermediate care facilities, which are other types of facility-based care. So this is sort of the broad umbrella of long-term services and supports. LTSS can be very expensive. So this is a challenge because Medi-Cal, as we'll go into in the next slide, but we'll stay here for a moment. Medi-Cal covers some of this, but as folks are aware, not everyone qualifies for Medi-Cal. And so if you have to pay for these things out of your own pocket, it can be very expensive. So as you can see, adult day, maybe $20,000, home health aides, up, over $43,000. Assisted living could be $54,000, and skilled nursing facilities being the most expensive. And these are median costs. And many people can't afford these costs, and so a lot of people do end up going without care and staying at home with unpaid family caregivers who provide a lot of care for individuals who need it and aren't able to access the LTSS system. So let's move to the next slide. So as I said, Medicaid or Medi-Cal here in California is the primary payer of a lot of these long-term services and supports. As you can see, Medicaid pays for the most of it. Medicare pays for a little bit, and we'll go into that in the next slide. And then you'll see that there's the out-of-pocket costs that people pay. There's very small amounts of private insurance for these types of services, and some other sources of payment. So let's move on to the next slide. So a very common misconception is that Medicare, which is the insurance that you get when you turn 65 or if you have a disability, is that Medicare covers everything, that it covers your health care, it covers all of your needs. Once you turn 65, you're home free. But that is not the case. Medicare coverage for long-term services and supports is very, very limited. Medicare only covers the first 100 days in a nursing facility. If you need to stay in a nursing facility for more than 100 days, you either have to pay for it out of your own pocket or Medi-Cal will kick in if you qualify for Medi-Cal. If you want long-term services and supports that are the home and community-based type kind, Medicare does not cover any of that. So Medicare doesn't have anything like IHSS. The only way to get in-home supportive services, IHSS, is through Medi-Cal. And again, that is the largest home and community-based services program in California, but it is only available for people on Medi-Cal. And so you'll see here that the eligibility for Medi-Cal is being at or below 138% of the federal poverty level, which this year is a little over $20,000 a year in annual income. And so now this is where I hand the baton off to our next speaker to start going through some of the specifics on some of these LTSS services. So I'm going to turn it over to Christina Mills, who is the Executive Director of the California Association of Area Agencies on Aging. Thank you so much, everybody.
Thank you, Yasmin. Again, I'm Christina Mills, the Executive Director of the California Association of Area Agencies on Aging. And I'm going to be talking about 4 programs specifically: Area Agencies on Aging, the Independent Living Centers, Aging and Disability Resource Connections, and Caregiver Resource Centers. Before I do that, I just want to share with you that if we were in person, you would see that I am a wheelchair user. I was born with a disability. I have multiple disabilities. My family members all have disabilities as well. So the folks that you saw in the video at the beginning of today's presentation are people that I can absolutely relate to. When I started my journey in determining whether or not I was going to leave the Medicaid system to go to work, it was a very, very big decision for me. Medicaid was something that I depended on for about 24 years of my life before making the decision to transition to work-based employer insurance. And I think that one of the other myths, like Yasmin covered around Medicare, a lot of times folks automatically assume that if you have some sort of substantial disability, which many people would consider mine to be, I would be automatically covered by Medicaid. And in fact, I am not. So when I made that journey and made that change from going from Medicaid to employer-based insurance, I said goodbye to Medicaid services. And in a lot of ways, that's been incredibly challenging because Medicaid is absolutely a long-term services and supports insurance that helps people with disabilities and older adults, oftentimes far better than employer insurance does. With that, I'll start with my next slide. So area agencies on aging are for folks ages 60 and over, and for older adults with disabilities, also for caregivers. Every area agency on aging has different services. There are 33 in the state of California, and I just want to briefly say that we're going to touch on it in the next slide too, but independent living centers and area agencies on aging are primarily funded through the federal government. And both of these programs are currently at risk because of the continuing resolution and what's happening on a federal level. The services that area agencies provide range from information referral, community education, care management, caregiver support, nutrition programs like Meals on Wheels, transportation assistance, sometimes paratransit to go-go grandpa or grandparents, legal assistance, insurance counseling, and long-term care ombudsman services. Next slide. Independent living centers are created for and by disabled people. So if you go to one of California's 28 independent living centers, chances are you will meet people with a variety of different disabilities that will be providing the services to you. It's based on a peer-driven model, and you will see people that have non-visible disabilities to folks like me that have visible disabilities. They have a set of what is called core services. And again, these are services primarily funded through the federal government: information referral, independent living skills, transition and diversion, housing coordination, advocacy, peer support, personal assistant training or services, systems change advocacy, and assistive technology. Next slide. Aging and disability resource connections are very unique, especially in the state of California. You will hear folks talk about it around the country, but California is the only state where independent living centers and AAAs, area agencies on aging, come together from the contract point in time to delivering the services and actually working in a coordinated effort to offer programs based on whether a person has a disability or is over the age of 60. And one of the things that I really appreciate about this program that I like to use an example to share with folks how these come together is during COVID, when there were a lot of folks very scared to go out and get food and otherwise couldn't get food at all unless it was delivered to them. While the aging community is known to have Meals on Wheels and other programs that can bring food to their homes, folks with disabilities, unless they're over the age of 60, haven't had that option. But through ADRC services, those systems could come together, and an independent living center might have the funding to serve nutrition programs for people under the age of 60, but not have the capacity to provide it through a program in existence. But they could often fund their coordinated program on the area agency, the AAA side, to do the home delivery services for people under the age of 60. So it's a wonderful opportunity for aging and disability services to come together. And within the ADRC framework, there are also a set of services: information referral, options counseling, service coordination, and transition services. In California, the C4A, my organization, the California Association of Area Agencies on Aging, and the California Foundation for Independent Living Centers established the initial funding, the $10 million through general fund, to get this program going in the state, and have since then not seen an increase. However, we've seen a lot of people, over 120,000 people, benefit from these services just last year. And we are doing a budget request this year to hopefully increase funding for aging and disability resource connections. Next slide. Caregiver resource centers are a wonderful way to get services and support for caregivers, whether it's getting resources, understanding what respite is in caregiving, understanding what it is like to get short-term counseling, joining support groups, professional training, getting some legal and financial consultation and education. The CRCs are also funded by the California Department of Aging. They also receive local sources and other types of grants as well. Next slide. And with that, I'm going to turn it over to my good friend, Tony Anderson at the ARCA.
Thank you. Thank you, Christina. Well, I was getting lost. I was following everybody and having such a great time learning with everybody else. So I hope you all that have joined us, that you're taking in a lot. I realize this is, as they say, drinking water through a fire hose, because it's a lot. But the really good thing about that is that we have a lot. We have a lot of different ways that we've gone about supporting people in non-institutional settings. So if you think about why we have created this robust system of community supports and services, is because we have learned over the years that supporting people where they want to be supported, it not only is a good thing, sounds good, but it's also good for their health, and it's good for our tax dollars as well. I'm going to touch on a few of those things. The other thing is, we might mention the word waiver throughout, and some of you that are new to this world may wonder what we're waiving. And so we just talk about, that people used to have an automatic right to institutional care, and you can waive that right of yours, and you can get community services and supports in a variety of other ways. So just in case those are coming up for you. And also encourage you, any other questions you have, please throw them out there as we go. So receiving care at home is a very, very important piece to our safety net system. And really, we have a large, robust range of services and supports for people with disabilities and for seniors. The supports that we have at home include anything from personal care, meal delivery. We'll talk about that. Some home modifications for some of the programs. There are a variety of other ways for your health, your nutrition, keeping you safe at home, and doing the things that you want to do in your life. And you'll find that most of, if not all of these services that we have really rely and speak about being person-centered. And some key areas talk about being person, consumer directed, and we'll touch on those that touch on that area. I want to tell you real quick, though, that my name, I tell you, I'm Tony Anderson. You heard that from Christina, my good friend, but I'm with the Association of Regional Center Agencies, and we support people with developmental disabilities in the regional center system, and I'll touch on that as we go. So next slide. In-home support services. In-home support services, one of my favorite areas in our safety net system, and I'm a proud former in-home support services worker. When I was in college, I worked in in-home support services, supported a friend of mine. Well, he became a friend of mine, and he had no use of his limbs. He was a brilliant man, helped me understand so many things in life. But my job was to help him navigate his community and get into his community wherever he wanted to. And so I did all kinds of things. But I did have that experience. I just say that because all of our home and community-based services struggle today in finding workers, and it's a great place. So if any of you are staffers now and you want to do some side jobs, I tell you, these are great jobs. Or if you have family members that are looking for jobs that are rewarding, come to our services and supports throughout the community. So anyway, IHSS, it's one really neat thing about IHSS is you'll read about the history of consumer-directed services. And IHSS was the program that began in the very beginning, and is sort of the shining star of participant-directed services in this country. So very large system. It grew out of the independent living movement, and really it was a chance for people to choose living at home, and then what would they need. So help with bathing, dressing, meal preparations. There are 600,000 people that are receiving the services in the state. And these are seniors and people with disabilities, and many also people with developmental disabilities in particular, and that we're familiar with. So to qualify, individuals must meet Medi-Cal income requirements. You submit an application. There's a process where you would do an assessment. What are your needs? What would the person that's going to come into your house, what would they do for you to help you navigate your community? So those are a big part of how that works. And then they determine the amount of hours. The hours they might determine that you need 24/7. And so one of the downsides here is that they're not going to authorize that many hours, but they will authorize about 283 hours a month if you need that. And so that comes to about 9 hours a month. So it doesn't cover all the things that you might need, but it is a very important system that we have. We also have people that they want to access this great person-directed service with all of the things that are available to them, but they're not able, for whatever reason, to direct the services themselves. And there are some other ways that they can access in-home support services as well. So move on to the next slide. Notice I'm halfway through, so I better zoom along. Adult day health centers, now known as CBAS, probably one of the best acronyms of anybody. CBAS, you will never forget that one. But CBAS is the new term and for the health, the adult day health centers, and the program is a community-based service. It's done in group settings. So unlike IHSS, CBAS is delivered in a center-based setting instead of in your home. But both programs have the shared goal of enabling people to stay and be part of their community. So CBAS provides a range of services, including getting there. So transportation is often a challenge for folks. So about most participants, almost all, about 98% access CBAS through Medi-Cal managed care, which means it's managed care. You connect with your managed care plans and rather than the state itself. And then also would just like to add, since you're all policy folks, that the rates have been not keeping up with the needs of the centers, and it's been a big struggle. They've worked really hard, and there's a advocacy campaign to make sure that the policymakers are really aware of that, and that they look at an allocation in the general fund to make up for the shortfall. It's a significant shortfall. Next slide. Regional centers. I could talk to you all day long about regional centers, but I'm not allowed to do that. But I will tell you that the regional centers now are projected in the budget year. The census is projected to be about 500,000 people with developmental disabilities. So, and what are developmental disabilities? For those of you who are unfamiliar, intellectual disabilities, autism, cerebral palsy, epilepsy, and other kinds of disabilities that are related to the needs of somebody with an intellectual disability. This is the first year in our history. This started in 1969, the first year in our history where the diagnosis of autism is now the number one diagnosis in our system. So it has just surpassed intellectual disability, which has always been the primary. We have an array of different kinds of services. We started off with assessment to see if you have a developmental disability. This could be very early in age, and so we support people that are right from the very beginning of life all the way through the end of life. So our services are all over. We have social workers who plan with people what are their goals at different stages in their lives and what can we do to help them. All of these services that I'm mentioning here, at some point, a person with a developmental disability could be accessing them. So all throughout school, throughout their senior programs, through work, people with developmental disabilities, hopefully you will see them more and more, because maybe 30, 40 years ago, you never saw people with developmental disabilities, but today you see them all throughout the fabric of life. And the funding is about 35% federal funding. It's on a waiver, Medicaid waiver, and a variety of other waivers, but the rest is state funded. And the great thing about the California system that's unique to all others is that the California system is an entitlement. So if you have a developmental disability, you are served. And in other states, that's not the case. Next slide. MSSP, the Multi-Purpose Senior Services Program. This is another showcase program that we have in California. This provides care coordination for frail older adults, 65 or older, who are Medi-Cal eligible and certified as being at risk of institutionalization. So they have to be certified of being at risk, and that's unique to that program, different than the other of the two. Even though the purpose is that you're not institutionalized, that's unique in that way. Rather than delivering services directly, MSSP does this in teams, including teams of nurses, social workers. They conduct the assessments and they develop care plans. So they have a team of professionals who help with your approach to your health, so you can stay in your community. So because the program has limited slots, you could be on a waiting list in some areas, and however, there are some who have done. There's some even private pay ability. So I'm going to have to move on. The Meals on Wheels. I'll tell you about Meals on Wheels. Those of you who are familiar with that, um, you're familiar with the fact that you could get meals delivered to your house, probably, for folks. Let's just not the Meals on Wheels. Can you move to the next slide? There we go. On the Meals on Wheels, so the services are meals, so that you will have nutritious meals delivered to your home, and at no cost. But there is no cost, but people are encouraged to pay, so that they can contribute to the cost of the program if they can. If they can't, then nobody is denied food if they can't pay. So, but in addition to that, there's also safety checks, as you see here, and really the intangibles of a social connection for many people who aren't able to get out, and they can spend some time chatting with people, and then they would be alerted to if the person is if there are any issues living in the home for the person. So there are a lot of other benefits to that program, and that's the Meals on Wheels program. And then we'll go right into PACE, the next one. So I note that I am over my time, but I'll go and I'll be careful here. The PACE program of all-inclusive care for the elderly. PACE, this is another exciting program. It's a one-stop for long-term supports and services care, offering integrated medical, social, long-term services. It can include doctor visits, specialty care, prescription drugs, therapy, personal care, transportation, so you get there, all coordinated through the PACE program. So this one-stop shop for getting all of your care needs done. Each PACE participant has an interdisciplinary care team, including all the medical folks that I just mentioned, and they work together to create and manage a personal care plan. And while the participants can visit the PACE centers for daytime services, most of the care happens in the participant's home. And to qualify for the PACE program, participants must be 55 or older and qualify for nursing home level care. And then the program is funded through monthly capitated payments from Medicare, Medi-Cal, some private pay, and services are free for Medi-Cal recipients, while Medicare beneficiaries who don't qualify for Medi-Cal can make those payments. Those they can make their own premiums. Okay, next slide, please. The senior centers. My mom used to love going to her senior center. Really, she lived for that. These are the senior centers throughout California serve as community hubs. It's a great way for us in California to combat social isolation, promote active lifestyles, develop more relationships, friendships with one another, connect older adults to critical resources that keep them in their community, keep them able to age in place. And unlike CBAS centers, senior centers cater to independent, older adults, focus on social engagement and recreation and the like. A lot of maybe fitness classes, art classes, general wellness, whatever, the mental health of a person, their enjoyment in life. So that's our senior centers, and there's so much more. And then the last part I had here was the private pay. Just noting that there are many different ways of doing private pay. I had mentioned some ways that you can pay for some of the services that we have in place yourself, but there are other ways that you private duty nurses and hospice care providers and then of course families. And families is a big resource for caring for their own. And so we have to take care of our families. And then finally, on that very last slide, I think is mentions the villages. And the villages is another option for family pay. This is developing more and more throughout the state. And I think there are something like 50 of these villages, yes, throughout the state today. They're often supported by volunteers and members that join them, and they coordinate social gatherings, education, and other activities to keep people engaged. So that is a lot. And so our next speaker is Lisa Coleman. She's the legislative director for the California Commission on Aging.
Hello. Welcome to this fast-paced world of long-term care. I am Lisa Coleman. I'm the legislative director for the Commission on Aging, and the Commission on Aging is in statute as the people's advocate. Our commissioners are tasked with speaking to the governor and to legislature and to state agencies and departments, both and federal, on anything impacting older adults. And due to a bill that we passed last year, that has been expanded to adults with disabilities and caregivers. So we have a huge playground, and I'm thrilled to be a part of this. And I think I got tasked with covering the receiving in communities because I don't like living alone. And it's about choice. And so while there are significant numbers of older adults that do want to live and age in their own home, there's also a group of us that are very social, and we prefer to age in a community setting. And so that refers to broadly assisted living facilities. Yasmin mentioned earlier, the formal title is Residential Care Facilities for the Elderly, so RCFEs. But they have so many different names. You'll hear people call it assisted living, board and care, 6 beds, large facilities. So whether you are thinking of those large apartment complexes that I like to call the cruise ships that never leave port, that have big activity rooms and dining areas and bus tours, but everybody has their own apartment where care is brought into their apartment. Or if you're talking about a more intimate setting, more like a Golden Girls environment, well, if it's a 6 bed or a board and care, where you have a smaller group of people that choose to live and age together. Really, it's all about choice. And so when we look at our assisted living facilities, and adult residential facilities are for those that are under the age of 60 that have a cognitive impairment. Typically, it's cognitive impairment that would foster a group environment. We have ARFs. So eligibility, broadly speaking, you need some assistance. Oddly enough, the biggest reason people look to assisted living facilities or for getting in-home supportive services is because they can't stand long enough to go to the grocery store, to buy groceries, to bring the groceries home, to prepare the meal, to eat the meal, and then to clean up after the meal. If you think about it, as just an independent person, if you think about your day and how much time and energy goes into feeding yourself, it's a lot. And so that is one of the reasons why we utilize in-home supportive services and assisted living facilities so that we can have nutritious meals. So we've got lots of different personal care services. When it comes to the funding, well, of the 220,000 plus assisted living facilities that are licensed in the state of California, the vast majority of them are paid privately. Just individuals that from their savings accounts, their pensions, their Social Security. There are those that have the long-term care insurance policies, but by and large, it's just private pay. Though a growing number of assisted living facilities, your stay can be covered through the assisted living waiver, about 14,000. But I'm very excited about a newer program that is provided through CalAIM, and it's the Skilled Nursing Diversion Program. So like the assisted living waiver, it uses Medi-Cal or Medicaid, we call it Medi-Cal dollars, to pay for the care that you would receive in an assisted living facility. You still have to have some income to cover the room and the non-personal care services. But in any case, the assisted living waiver and the CalAIM can cover care on assisted living. So the next slide. This, again, it's the private pay. So independent living facilities, we're seeing more and more of them. They are really apartment complexes that kind of cater towards older adults. They don't provide any personal care, but they have housekeeping, and maybe they'll have, they have meals and activities and transportation. It's kind of like living in a dorm. It really is. You have the opportunity to eat foods, you have the opportunity to engage, but you get to go back to your own space at the end of the day. Private pay assisted living, as I said, that's the vast majority of the little over 220,000 licensed facilities we have in the state. Private group homes, this one is a little tricky because when we're talking about congregate living, it could be foster homes, it could be sober living, transitional housing, but it also does include people that are living in board and cares. And if it's a board and care, it has to be licensed. And then we have the retirement communities. And the retirement communities can be very much like the independent living facilities, but it typically, a retirement community has levels of care. So a person buys into these groups, and then they may start out independent, and then as they age or as their care needs grow, they might move into an assisted section of the community, and then perhaps ultimately moving into a skilled nursing part of the community. So I have like 30 seconds left. And the one thing I would like to point out, as I said, it's about choice. We want to make sure that Californians can age in the setting that they desire, but also that works best for them. And I think we have to be very careful when we talk about institutions, and no one wants to go into an institution. The truth is, many of us cannot control our disease process. I may ultimately need to have medical care 24 hours a day. And as has been shared, IHSS, fantastic program, relies on family and unpaid caregivers. And not all of us have family that live nearby. We have a very large number of older adults that live alone, where their family, either they never had children, or their children died, or their children have moved away. And so I just want to highlight that assisted living facilities is an alternative for those that wish to age in the community, but among other people. And now I get to hand it off to Jason Harper. He is the Association Director for the California Long-Term Care Ombudsman Association. Take it away, Jason.
Thank you so much, Lisa. Good afternoon, everybody. I'm Jason Sullivan Halpern. I'm the director of the California Long-Term Care Ombudsman Association, and we represent all 35 of the local long-term care ombudsman associations across California. And I'm here to just quickly cover some of the options for older adults and adults with disabilities who need a slightly higher level of care. Next slide, please. The first is intermediate care facilities. They are what they sound like, somewhere in between a nursing home and independent living. These are for individuals with significant developmental disabilities requiring skilled nursing, but not a constant hospital level of care. There's a number of different services that they provide, and they are largely funded by Medi-Cal with oversight from the Department of Public Health, Department of Healthcare Services, and CDA's Long-Term Care Ombudsman Program. Next slide, please. And finally, you've probably heard of these before, skilled nursing facilities. They provide a 24/7 level of care for individuals with serious medical conditions. In order to be eligible, you have to have a medical condition which requires regular nursing care and other health-related services. They provide a hospital level of care. So as you can see, the list of services provided is quite long. And these are funded jointly through a combination of Medi-Cal, Medicare, private insurance, such as long-term care insurance. They are licensed by the Department of Public Health and overseen by the Department of Public Health's Licensing and Certification Program, with additional oversight from the Long-Term Care Ombudsman Program. And now it is my pleasure to introduce Monica Kirkland from Senior Services Coalition of Alameda County to finish off this presentation for us. Take it away, Monica.
Awesome. Thank you, Jason. My name is Monica Kirkland. I am the State Policy Director for Senior Services Coalition of Alameda County. And I'm going to dive into the vision for long-term services and support. So as we conclude our discussion on LTSS, it is crucial to recognize that systemic challenges that must be addressed to ensure all Californians can access the care they need. So let's start with navigation. First, navigating LTSS remains a significant challenge for individuals and families. Services are not universally available across California's geography, and eligibility requirements vary widely across programs, creating some confusion and some limiting access. So a no wrong door approach is needed to streamline access, ensuring individuals navigate and receive the supports they need, regardless of where they enter in the system. And let's look at financing, right? So LTSS is expensive. I know we've heard some of that from our prior colleagues, and options are extremely limited for those who do not qualify for Medi-Cal but cannot afford private care. So by 2033, California will have over 1 million individuals who will be at risk of depleting their resources just to qualify for Medi-Cal in order to have access to long-term services and supports. But those with incomes between 58,000 to about 95,000 a year are not likely to qualify. But at the same time, they wouldn't be able to afford long-term services, right, without selling their homes. So California at the moment is grappling with strategies to support middle-income individuals, often referred to as the missing middle. While we've made some great progress in expanding the safety net to capture those just above the Medi-Cal threshold, more work needs to be done to address the affordability challenge facing our aging population. And when it comes to workforce, California is experiencing a critical shortage of paid care workers. So these essential workers, primarily women, many of whom are immigrants and women of color, are often underpaid and lack access to benefits. So addressing this challenge requires improving compensation, training, and career pathways to really ensure sustainable LTSS workforce. And at the same time, the system is heavily reliant on unpaid family and community caregivers. So what does that mean? Those who provide over pretty much 80 billion in economic value annually, yet they receive minimal support. So these are our family members and our community caregivers. So unpaid family caregivers are often women, particularly women of color, who are juggling work and raising children on top of caregiving responsibilities. And also, let's look at access. Lastly, but not least, as California's aging and disabled population grows, the need for LTSS will continue to expand, and we must ensure that our system of care has the capacity to support this demographic shift. So, however, low reimbursement rates are leading to program disclosures. We're seeing this play out in real time with the closures of community-based centers. So at the same time, programs like the Assisted Living Waiver are not currently available statewide and often have long wait lists. As of December 2024, literally last month, nearly 8,000 individuals were on the wait list for assisted living, a number that is likely to continue to grow. And rural communities, they face particularly stark challenges due to fewer available services and providers. We can go on to the next slide. So how does that also play? What are we doing about this, right? So we have our California Master Plan for Aging. And so California's Master Plan for Aging, it really provides a critical roadmap for addressing these challenges and ensuring a stronger, more equitable LTSS system. So born out of an executive order and developed with robust input from stakeholders, the MPA is a 10-year blueprint aimed at creating a California for all ages and abilities by 2030. And the MPA has 5 bold goals, right? And they're focused on housing, healthcare, inclusion, equity, and caregiving and affordability. So, in terms of LTSS, some of the key priorities would include expanding access to home and community based services and addressing regional disparities. Another one would be strengthening the LTSS workforce and enhancing the caregiver support and developing a comprehensive no wrong door navigation system, and finding solutions to address affordability of LTSS for our missing middle population that I mentioned earlier. And so by doing this work, which I know seems like a lot, we're not only supporting older adults and adults with disabilities, but also families, caregivers, and communities across the state. So I want to wrap up today's session by thanking each of you for joining us today. Please know that the Collaborative's vast membership is happy to serve as a resource. So if you're looking for information on LTSS, a deeper dive on specific programs or policy, or to connect with the providers and advocates or even consumers, we are here and ready to be supportive. So on behalf of the Collaborative, we thank you for your time, and we look forward to partnering with you to build a California for all ages and all abilities. And I hand it back to Maria.
Thank you so much, Monica. Appreciate everybody's time. We're going to close out. We're going to circle back and share the slides and additional resources. Please feel free to reach out. And we look forward to partnering with you. And I hope you have a wonderful rest of your Thursday.